Hello to everyone and welcome back to my channel. My name is Tommy. I'm a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize the classes of the university to then explain and teach you the best and most valuable information you need to know. Today we're going to continue the dietotherapy series of videos and we are going to talk about dietotherapy in different individuals. So let's begin. Dietotherapy in the surgical patient. We already know that malnutrition problems that there are in the hospitals, and I have done a video talking about that in more detail. What we do now is to take a look at the perioperative nutritional support. Perioperative is around the operation, around the surgery. It is a multimodal rehabilitation or an enhanced recovery, what we are looking for. Preoperative fasting may lead to malnutrition, and we are going to see that in a minute. Changes during a surgery. Aggression. There is an increased energy expenditure because of the aggression. Protein hypercatabolism with increased urinary excretion of nitrogen. Hyperglycemia and hyperinsulinemia, which can cause insulin resistance. Mobilization of fatty acids and triglycerides. Water and sodium retention, as well as mineral and urinary losses of zinc, magnesium, phosphorus and potassium. So we lose a bunch of minerals here. What do we do? Anamnesis. The need of screenings before the surgery and a nutritional assessment plus the anthropometry. So what we do here is to gather information to know if the patient already has a malnutrition or not. Again, I explain this in much more detail in this video right here. Preoperative fasting, the one that it is always recommended. Well, the literature now says that it is nonsense, since we only need 90 minutes to empty the stomach. You can eat up to 6 hours and drink up to 2 hours before the surgery. This is the recommended now. Also because fasting prior to a surgery can lead to mitochondrial dysfunction, metabolic stress and possible insulin resistance. In the majority of the individuals, of course. The ERA's guidelines recommend artificial nutrition only at certain times. And artificial nutrition, I've done a video talking about that. On the other hand, post-operative fasting, it is nonsense as well. They say that the small intestine needs between 6 to 12 hours to recover the peristalsis, the stomach from 12 to 24, and the colon from 48 to 72. So from 4 to 24 hours after the surgery, you can start with a liquid diet and then progress to solid or directly solid if tolerated. This is the progressive diet we've seen in the first video. Artificial nutrition again, only if needed. Now it's called the nutritional therapy. Before it was called the nutritional support. And after a surgery, we have to check the glycemia. The glycemia must be between 150 and 180 milligrams per deciliter. The RICA recommends it to be between 110 and 150. And the ERA's guidelines, they just recommend to avoid the hyperglycemia. Remember, why the glycemia raises? Because there is an aggression here, hyperglycemia and hyperinsulinemia. So now in detail, the nutrition and organ transplantation. Transplant receivers have malnutrition, and if they are obese, the complications increase. Nutritional support in the donor. So if the donor is a cadaveric donor, there is a hypercatabolism with elevated catecholamines and inflammatory mediators, of course, and we have to ask ourselves, does it have parenteral nutrition? If yes, then we continue. We can also give enteral nutrition, which is effective but is poorly tolerated since the donor is dying. So what we do is to maintain a control. Living donor, on the other hand, we have better survival than the cadaver, of course. We are talking about the organ here. And in the obesity, well, there is poorer survival and worse recovery after it. So complications if there is obesity, again here. Nutritional support in the receiver, there is malnutrition, well, worsens outcomes and reduces the survival. There is obesity, so the other way around, it increases the complications. And we may have to think about a possible pre-transplant bariatric surgery to remove a little bit of fat. In the sarcopenia, Well, this is an important prognostic factor, and it is related to mortality, graft survival, mobility, and functional capacity of patients. How do we preserve the organs? Because the organs go through the ischemia perfusion syndrome. They suffer a first warm ischemic phase, then a cold ischemic phase, and then also a deleterious metabolic change because of the new blood. So this is when we get it out of the body, warm ischemic, cold when we store it in the fridge, whatever, and the deleterious metabolic change when we reattach it to a new body and there is new blood, new circulation going through it. And all of this is called the ischemia reperfusion syndrome. So now let's take a look at transplant type and the phases. So what do we do pre-transplant, during, and after? In the liver transplant, pre-transplant protein from 1.2 to 1.5 grams per kilogram per day, carbs at 50-60 and fats at 30-35. Avoid prolonged fasting periods. During the transplant, early enteral nutrition or the complementary parental nutrition may be necessary. So the majority of the times the mixed nutrition is recommended. Post-transplant, we increase the calories and the protein, moderating fat, and we recommend the 1.5 grams of calcium as well as multivitamins until nutritional recovery. In the kidney transplant, pre-transplant obesity is not an absolute contraindication, although increases the complications. And we have to take a look at possible bariatric surgery prior to the transplantation. During the transplant, do not require specific nutritional support. Post-transplant, frequent weight gain, this is possible diabetes occurring. We increase the fat, we lose the muscle and the bone, but this undesirable gain is not in everyone, because this weight gain may be good in those patients that must avoid malnutrition at all costs. In the pancreas, previous kidney transplantation, because when you transplant the pancreas, you probably transplanted your kidneys as well, because if you have no pancreas, no insulin, high glucose levels in the blood, and these are going to damage the kidneys as well. So you do first the kidney transplant and then the pancreas transplant. Previous kidney transplantation, we load the protein and the calories and the weight if possible. Obesity worsens the graft and the individual survival. Immediately after finishing with the transplantation, the organ is functioning. There is no insulin treatment required, and we can restart the oral nutrition in 2 to 3 days. Post-transplant recovers the functionality of both organs, so pancreas and kidneys. General population recommendations here. So eat normally. And the obesity leads to diabetes reoccurrence. In the lung, well, the emphysema causes malnutrition. The cystic fibrosis will increase the calories burned, so the total daily energy expenditure, because of higher respiration. They start to breathe a lot. 30 to 50% of them have malnutrition. We recommend oral or enteral nutrition to increase their muscle mass. Then we say that oral feeding usually begins after 1 to 2 days, and we may have to administer the pancreatic enzymes in the case of the cystic fibrosis. In severe cases, we recommend the enteral nutrition via gastrostomy or gastrojejunostomy, so a hole in the stomach, and in cystic fibrosis, the use of oral nutritional supplements to, again, avoid deficits of nutrients. In the cardiac transplantation, we have to keep the weight between 90 and 110% of the ideal weight of the individual. We have to lower the sodium to 2 grams a day. We increase the protein, 1.5 to 2 grams per kilogram per day. There is a possibility of including oral nutritional supplements as well. Basal energy expenditure multiplied by 1.3 to 1.5 and the protein at 1.2 to 2 grams per kilogram per day. Oral nutritional supplements may be necessary. So again, here more or less the same. Calorie adjustment of the diet and gradual exercise, keeping the weight within the recommended limits after the surgery. In intestinal, this is for example the short bowel syndrome due to the mesenteric vasculopathies, trauma and Crohn's disease. the transplantation is because of these things. Infectious complications are the main cause of morbidity and mortality in these transplants. Parenteral or enteral tube feeding, because indeed you cannot really use your intestine to absorb those nutrients, therefore the parenteral is the main one. Progressive bowel rehabilitation, using the progressive diet as well. Oligomeric or polymeric enteral diet, lipids are introduced from the 4th week onwards, because lipids are the ones more difficult to digest and absorb because they require different mechanisms and they are not recommended in these circumstances. Then in hematopoietic precursor cells transplantation, well, we use chemotherapy here, and this leads to individual assessment and therefore to screening to actually see if there is malnutrition or not. Therefore, we give dietary advice and or oral nutritional supplements to avoid deficits. We have to avoid hard texture food, acidic food, or extreme temperatures. Hygiene here is very important, and we have to eat very clean food, avoiding, for example, the cheese with a lot of bacteria on it, the meat, the liver, all those things that are not really clean. Enteral nutrition is preferred rather than parenteral because of the risk of infections of the parenteral one. In the acute phase of the transplantation, we have to change the diet to control the symptoms. In the chronic one, we have to treat the diarrhea, lower the fat of the diet, lower the residues. Residues are minerals and proteins, and the oral supplements may be needed to avoid the deficits. If it is severe, the circumstance, well, we use artificial nutrition and we progress with that. Okay, so now let's take a look at the dietotherapy in eating disorders. What are eating disorders? Altered eating behavior that compromises health status. 13% of prevalence of eating disorders. Majority age group are between 15 and 19, and they tend to be females. It is multifactorial. Biological factors, neurological factors, psychological, developmental, and sociocultural factors are all involved in the occurrence of these eating disorders. The main one is the anorexia nervosa, which is pathological fear of weight gain. The diagnostic criteria, so ICD-10 criteria and DSM-5 criteria. This one tends to be more accurate. But let's view them one by one. So if you have a body mass index below 17.5, if you avoid the food consumption, if you abuse anorexigenic drugs, if you have a body image distortion, female amenorrhea or male lower sexual desire and impotence, and as well in the puberty, you don't grow very much and the girl's primary amenorrhea and the boy's infantile genitalia, then chances are the individual that has this suffers of anorexia nervosa. A much more detailed criteria is using the DSM-5. It has 3 criterions. Criterion A is the restriction of energy intake. The criterion B is the fear of gaining weight. And the criterion C is the distortion in perception of body image. Knowing that, we can distinguish the restrictive type of anorexia nervosa and the binge purge type. The restrictive, in the last 3 months, there is no binge eating or purging behaviors. And the binge purge, well, there is a binge eating or a purging behavior in the last 3 months. And we say that these individuals are in partial remission when the criterion A is not met for a prolonged period of time. But the other two, yes. Complete remission is when there is no criterion fulfilled for a prolonged period of time. So none of these. Bulimia nervosa, which is characterized by compensatory measures such as self-induced vomiting. Diagnostic criteria, again, ICD-10, it says that continuing concern, attempt to counteract weight gain, and morbid fear of gaining weight. People that have these, chances are they suffer bulimia nervosa. Again, the DSM-5 criteria is much more accurate and says that eating a lot of food in a short period of time, loss of control during the ingestion, and binge eating and compensatory behaviors at least weekly for 3 months. Partial remission, some criteria continue to be met, one of these. Complete remission, no criterion is fulfilled, so none of these met. And then we have the binge eating disorder, binge eating without subsequent purging behaviors. The difference between these two is that here we have purging behaviors and here we don't. And here there is only the DSM-5 criteria, which says that eating a lot of food in a short period of time, loss of control during the ingestion, binge eating, which includes eating too fast and too much, getting unpleasantly full, eating alone and feeling disgusted with oneself, weekly distress and binge eating for 3 months, and no compensatory behaviors are the characteristics of binge eating disorder. The partial remission, less than 1 episode a week. Complete remission, no criterion is fulfilled. And all of these have different grades of danger. So starting from mild, the occurrence is from 1 to 3 per week, moderate from 4 to 8, severe from 9 to 13, and extreme 14 per week. Then of course, what do we do with these people? When we diagnose them that they have in these eating disorders, what do we do? Well, we get the clinical history, the anamnesis, the physical exploration, the anthropometry and the blood tests. Then maybe they need some artificial nutrition to regain the ideal weight using special formulas. And also we need to avoid the refeeding syndrome using an adequate nutritional plan, mainly in the anorexia nervosa, because this is very common in those individuals, the refeeding syndrome. And then last but not least, we talk about the dietotherapy for allergies and intolerances. Well, the main thing in allergies is to eliminate the food that causes the allergy. But it's not that simple. We also have to educate the patient. He or she has to know which ones are the food that he or she can or cannot eat. So they have to know the composition of the food as well. Of course, the diet must be personalized and adequate. In cases of milk allergy, this is an allergy to the protein of the milk, to the casein, not to the lactose. The lactose is an intolerance. The milk allergy has to do with the proteins of the milk. We give calcium and vitamin D supplementation because we cannot really give them any dairy products. And dairy products are a very good source of calcium. And why vitamin D? Because vitamin D has to do with calcium and bones. And I also have to tell you that human breastfeeding is always better than milk formulas because they prevent the occurrence of milk allergy. In the celiac disease, well, we have to follow a gluten-free diet because this can trigger an anaphylactic shock which can be lethal, so we must avoid it at all costs. Just to remember you, allergies are mediated with an immune response, intolerances not. Allergies are differentiated between the ones mediated with immunoglobulin E and the ones that are not. Now talking about intolerances, we have 3 types: enzymatic, pharmacological and undetermined. The enzymatic, the most frequent and most famous one, is the lactose intolerance, where the lactase, the enzyme, doesn't work properly. Then there is also intolerance to fructose, sorbitol and sucrose. The treatment in the lactose intolerance is to find tolerable amount of lactose and stick to it. Fructose, we have to remove it completely from the diet because this can accumulate, and the metabolization of fructose only happens in the liver. And fructose can really act like a sort of poison in the body if it accumulates. But where do you get the most amounts of fructose in your diet? Using sucrose. And sucrose as well, you have to remove it from the diet if you have an intolerance to it. Sorbitol, though, you have to reduce the amount until there are no symptoms. In the pharmacological, we have the histamine, and we have to reduce histamine-rich foods, such as the pork. Pork meat has a lot of histamines, and it is also correlated with inflammation. So we have to reduce histamine-rich foods. And the intolerance that it is undetermined, it is the irritable bowel syndrome and also the gluten intolerance. This is not the celiac disease because it is not mediated with an immune response, but you just don't feel good when you have gluten. For the irritable bowel syndrome, we have to avoid the FODMAP. FODMAP are the fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, so short-chain carbohydrates that can ferment in the intestine. And for the gluten intolerance, guess what? We have to avoid gluten. Okay, that's it for this video. Thank you so much for watching. You can find this diagram in the first link in the description down below. You can download it from my website and study it very well. Remember to like this video, subscribe to my channel for more content like this. If you appreciate this, also share it to your friends and family to let them know that I'm doing these videos. Thank you so much for watching, and I will see you in the next one. Ciao!